important of aspirating before OCD, you can take a stent directly as much as 50% of the patients, which echoes with the presence or occurrence of ACS in patients with relatively milder disease. And this is the final result. So this fear has been sitting on our mind, a large ostial LED thrombus, and you have a risk of occluding a dominant left circumflex. And this thrombus migration into the side branch or distal embolization, this virtually went away with the data from the CHEETAH trial that had a distal embolization rate of only 0.75%. So, like in the earlier cases, just one single run of cataracts and you get a beautiful result subsequently. The aspiration time is just 40 seconds, clinical flow achieved in just 120 seconds. So again, echoing what we were talking for years, time is muscle, it helps us revascularize the distal myocardial bed in the true form. So this is the data from the CHEETAH study, 97.5% clinical flow at final angiogram with just 0.75% of distal embolization rate. So the aspiration power comes from the lumen, the vacuum technology that is persistent negative minus 29 inches of pressure all across the aspiration window. You can do it with a 6-branch catheter if you are using one wire, or if you are using 2 wires, you need a 7-branch catheter. 112% more aspiration efficacy. Why we need it? Because it's an attractive alternative in high bleeding restrictions and may give us better protocols in patients with underlying plaque erosion. This was a young athlete who was after thrombus aspiration. You see very minimal plaque, very minimal red thrombus, pratic grade 1 if at all I want to say, and on medical treatment for 20 months now, not even received a death in this situation. Some cases there is of extreme benefit, left brain hepatic vessels osteoartery, where the echocardiographic improvement is also very good. Examples of hepatic vessels are CA, LED, I'll skip the details. Even in post-pulmonary angioplasty, sometimes if I have slow flow, I've been using it, it's pretty helpful. It tracks acute lesions, acute takeoff lesions as well. Even when the microcatheter is traversing with difficulty, this is a protocol that we've developed and we sent it to American Heart Journal and accepted the case study. It starts with aspiration, followed by vasodilators, followed by imaging, and then stenting if we need it, as shown. It leads to lesser use of pre-dilatation balloons, lesser stent length, lesser thrombus, lesser microvascular obstruction, lesser no flow, lesser distal embolization, higher post-dilatation pressures, higher rates of complete revascularization if I want to do a bifurcation setting right at the same setting. And we call this approach as minimalism to maximalism. Another interesting case of post-AVR stuck valves with occluded both LED and LCX. We aspirate thrombus both from the occluded LED and LCX. This is a large diameter, 4 mm, 4.5 mm vessel, both LED and LCX. Needed multiple runs, but on IVUS, no residual plaque, and we can get away with just thrombus aspiration and a beautiful result. Knowing the cause of underlying stent thrombosis, I skip this case, and the future lies in doing something with OCT just like angioscopy and documenting the residual thrombus. And this is the data, our own data. We have significant improvements of LVF at 6 months also. We definitely need randomized controlled trials. So I'll conclude my talk. We are going back to basics by assessment of the thrombus burden. Simplicity, common sense, and basics should take precedence over random trials that did not assess the thrombus in its essence. And we would recommend mandatory aspiration in all LTV cases, giving vasodilators and letting the vasodilators reach the distal bed, and imaging and or before stenting, before we actually stent such vessels with minimal underlying plaque. Thank you.
Thank you, Tanuj. Just quick comment, then we can go to the other chairpersons. A very important comment which I want to make at this point of time for the young people, that once you cross the wire in a large thrombus, it's very, very important not to do pre-dilatation. Once you put a balloon, you have huge chances, very much chances that the the thrombus will further migrate. So don't do pre-dilatation, just do a thrombosuction, whatever catheter you are using, thrombosuction, and try to achieve maximum. You may have to do 2-3 passes if you are using an export catheter, 4 passes. Recently we had a large MI, thrombus just at the Austrial, a lady, young patient who had a cardiogenic shock and also was having DC shock at the time. So at this point of time, you just do this, no pre-delegation, have achieved good flow and then put the stent. That's the most important thing, no pre-delegation. Yes, further.
Very nice presentation, something which is new for us to learn and probably buy. But what is your take probably for high thrombus burden? Like to have something which actually reduces the platelet accumulation, as well as we need something in a small pool, small diameter, like laser. So laser has a property that actually inhibits platelet accumulation. That is what is required in acute MI, and it annihilates, it vaporizes the thrombus there and there, so that when you are aspirating, probably it still carries a 0.7% chances of getting into the side joint or LCH or coming to the left vein. Laser that is also avoided, and then this side of the diameter is 0.9. So you can go really to the distal part and have lesser chances or almost no chances of go.
So I'll put in 2 points that come to my mind. Point number 1, laser could have a difficult learning curve as compared to a device that we could be having right on table and getting it in protein. Secondly, thrombectomy for thrombus, laser for thrombus and plaque both. Laser fits thrombus and plaque both. So the only thought why we developed this ABS protocol was to understand the plaque. We were not trying to understand the plaque that was leading to the ACS. And after thrombus aspiration, we actually know maybe the entire data of plaque erosion, plaque rupture, and calcified nodule or SAL would change in entirety once we do the entire study again with after thrombus.
So laser learning curve is only single.
I think we have to cut short now.
And what about money?
Only last.
I'll just ask you, so laser not come, probably laser and HEP would have done everything.
Sir, this device,
Because that's the probably this technology.
plus this device doesn't literally have any complication.
Did you do OCT after the aspiration?
Yes, sir. That is one point which I mentioned, that a huge impediment to imaging is the earlier thrombus. So we have to aspirate the thrombus.
Yes.
So we do that.
And you aspirated and then you did OCT. My question is, what was the residual burden of thrombus after you have done it in your 100 cases?
Yes, sir. Sir, I would means if.
Would you have to do it again? That is what I'm
Sir,
asking.
we were in midway when we started developing this protocol and documenting it with a Pratt grade. It's difficult because baseline we don't know. After aspiration, we can give.
Of course, and that is the question. You wouldn't know, so you have aspirated, and what percentage of your cases you had to go in again? That is what I'm
Sir,
asking.
we needed 2 to 3
Based on
runs.
your OCT findings.
Yes, so we needed 2 to 3 runs in most of the cases. So as we learn, there are certain times when once we aspirate and we do have no angiographic thrombus, but on OCT we have high residual thrombus.
That's right.
That is the point of time when we actually aspirate. That would be hardly 10% of our cases.
Thank you.
So you have the last comment.
What is the blood loss?
Absolutely nothing. So that aspiration penumbra for peripheral things is a different ballgame. In fact, they have now AI-enabled software where they detect thrombus versus blood. But in this, we have even documented the drop of hemoglobin was 0.7 grams per deciliter.
Okay, finish. Short comment. Next speaker, please. Dr. Praveen Chandra. Is he there? So now we go to the third speaker, Dr. Suresh Kartik.
to come on stage and
We will be talking on cardiogenic shock.
No, he's talking on my challenge.
For the my challenging primary PCI. Okay.
Suresh Patel or Yashpal Sharma?
No, just Sharma to put it.
Good afternoon, everyone. I am asked to show a case actually of cardiac angioplasty patient. That's what when they sent me the note. So then subsequently they told me that you speak on primary angioplasty with cardiac. But I thought I would show a case of angioplasty. I'm not talking of a transmural infarction, cardiac shock. I'm talking of a profile positive patient with the cardiac shock, and how did I manage this patient, and let us see what it is. My patient is a 64 years old male. Actually, he has a long-standing diabetes, he is hypertensive, he has got a CKD, he was on maintenance dialysis for the last 5 years. He has been having ongoing angina and dyspnea for the last 6 months, which got worsened in the last week time or so. And so the patient was taken up for cath study elsewhere, and the angiogram was done where they found that he has got severe disease, and they referred the patient to our center to a nephrologist to undergo a dialysis, and subsequently you undergo a CAPG in that center. So I was not at all in the picture at the till here. And as usual, the nephrologist referred the patient to the surgeons, and surgeons saw the patient. The moment when they saw the patient and the note of the patient, they refused to operate the patient. So then the case was referred to me. They told me that sir, this patient is there who has got a CKD, diabetes, obese individual, his blood pressure is 80, tachycardia, and they have referred for angioplasty too. So actually, when they told me all these factors mean that we are going for a very high risk patient, whether I should do the procedure or I should also see it. So I saw the patient. When I saw the patient was tachycardic. His blood pressure was around 80, but patient looked comfortable with a respiration rate of 24 to 26 per minute, and his notes showed that he was a Prof positive. I reviewed the echo showed the LED area was hypokinetic with ejection fraction of around 35% and grade 2 MR. So I spoke to the patient and patient relatives. I told them that this is a high risk patient actually. You are on a maintenance dialysis. There are multiple risk factors which make us feel that you will be probably requiring multiple admissions, and morbidity and mortality that is associated with this disease is quite high. And when I spoke to the relatives told me, sir, will go on medical. I said, you take over and let us know. But on that day, the patient was taken up for dialysis. Patient went into acute onset of breathlessness and hypotension with a blood pressure of 60. Then again, they called me that patient relatives are now willing to take the risk. So you go ahead and do the procedure. So what I planned was we started him with inotropic drugs with noradrenaline, dopamine, and visual drugs. Then put the patient on IABP, and patient was ventilated. I'll just show you the angiograms. This was his angiogram. Calcific coronaries, left main calcium, medial AD, calcium even in the distal AD, ostial circumflex as a block of calcium in the distal left main, ostial circ were all diseased. Story doesn't end here. Just look at the RCA. The right coronary artery also has got multiple blocks of calcium sitting there. So here I had a patient who has got a severe triple vessel disease, calcific, which will be on ventilator with the IABP, and this one. So decided, planned it, and told the relatives again, recounseled them, because what is the on IABP and ventilator with severe triple vessel disease, diffuse disease, mortality as high as 50% can be there. If I do a successful procedure, patient, how long do you, because this one is challenging, I said, they said, okay, go ahead and do it. So I planned to do a rotational atherectomy for LED LCX, and in fact it was taken as a semi-urgent procedure. Patient was taken up for dialysis, hypotension. Then I had to quickly go ahead and plan the patient for a procedure. Then I put a long 3 by 40 mm desk from proximal to mid LED. Then the time for to do rota for the distal left mid to the proximal LCX. Once this was done, I had to use a Wolverine cutting balloon for the ostial circumflex to open up. And once that was done, I put the stent from ostial left mid to the proximal LCX. Then the LED lesion was crossed with the silent view. A stent was deployed 3.5 by 12 millimeters, and the procedure was ended by doing the simple casing technique. I did not go for the right coronary artery at this stage because we required additional devices, multiple blocks of calcium and all were there. So I thought let the patient get settled down at this stage. If the patient comes back to me, let me see whether I can do that procedure at a later stage. And the patient was shifted back to the ICU. Patient did remarkably well. He recovered and patient went home. I thought that he will not come back to me for further follow-up or treatment. And luckily, patient relative that this one fine day, my register calls me and tells us so much to come and he wants to get admitted for the right coronary artery angioplasty. I said, okay, you will get admitted. By that time, I had forgotten his right coronary anatomy. Then the moment when I saw the anatomy, there was dense loss of calcium. The battle was not just over, then the patient who had recovered. So again, this time I decided to do a rotatricity. I do a rota followed by an IVL and then do the procedure because it's a long RCA segment disease. So brought the microcatheter and the wire, but the microcatheter was just not passing across. I have taken out some pictures from this. So keeping the microcatheter proximal to the mouth of the calcium block, protocol to wire was passed, and then the budding was done. After that, I thought I would use an NC balloon and dilate it and see. When I took a 3 and 15 millimeter NC balloon, when I inflated at 10 to 12 atmospheric pressure, the balloon in fact got ruptured, indicating the severity of the calcium and the dense calcium that was there. So here at this stage, I have decided to go with the IVL balloon 3 by 12 millimeters. Multiple shocks were delivered at various points. Every point there is you can see the residual stenosis was there. These were some of the OCT pictures which were done with the cuts and the calcium that what you can see. And then I deployed 2 stents, one distally and one bit to distal to proximal and then bit to proximal. Then I did an OCT. This is the OCT line. Multiple blocks of calcium with adequate cuts and well deployed stent was there. Here one interesting thing happened actually. If you concentrate at between 48 to 49.50, there is the geographical release of the stent was there. So many things were happening for this patient at this stage. There was a geographical miss and then this was the stent and you can see that there was a geographical miss. So I had to put another stent of 3.5 by 8 millimeters in the part and this was the final shoot. So this patient is now almost 8 months since the procedure has been done. Patient is doing very well, he has been coming regularly for the follow-up. Now the question comes, how do I treat usually the primary angioplasty when I come to me with a cardiogenic shock? Usually my protocol has been very simple. Put the patient with the blood pressure is less than 70 millimeters of mercury. I start them with upfront noradrenaline. Then once the blood pressure improves, put them on inotropic support with dopamine. And once it is more than 90, I put them on dopamine. Then take the patient for a procedure. Usually, an infarct-related artery is treated on that day.
Will you please conclude because there is so much to discuss in this case.
Yeah, please go ahead.
Yeah. Okay. Thank you very much. So this is one of the most difficult cases that cardiologists face, and you did such a good job. We have some reservations about the expansion of the stent, but I think given the extent of the calcium, it was as good as it could be. What I was missing in your first angioplasty was the intravascular imaging, because it would have increased our insight into what you were facing. And we thought that there was a calcium nodule in the left main.
Yes, there was a calcium. In the first case, I did not do any imaging because the patient was hypotension 60.
Yeah, fair.
Wanted to come out from the cath lab.
Yes.
I was very apprehensive more than the patient relatives. I was very
Yes, fair enough. The thing also that I missed was when you went in to do the RCA angioplasty, we couldn't see the lady. You must have taken
I
the
have
picture.
taken
Do you have the picture?
I don't have the pictures here because
Yeah.
of the time, what has been given.
So what did you see?
No, it was normal actually.
Absolutely same as before?
Same, absolutely.
And this was 2 months down the line.
Yeah.
Okay.
And in fact, that's the reason the patient came back to me. I was not
Yeah.
expecting the patient to come back to me.
But why you were not expecting to come back? You had done a good
I
job.
thought that this guy may not make it.
Acha, one more thing we wanted to. Okay, let me
He was
leave
so
it.
sick, actually.
Yeah. This patient had normal ejection fraction, cardiac shock.
No,
EF
no, sir.
30%.
25.
It was directly.
Has it improved now?
Yeah, it has improved. It was hypertensive myocardium.
There are people who would be doing a single procedure staging, then of course you have to do right first and then the left. In case you want to do, just for learning, in case you want to do the case complete revascularization in one go, then it's better to do the right first, make it better, then only you can do the approach. This is another approach I was just thinking. Of course, you did a good job, but you had distal left main lesion also. You did not cover that, I think, because you did the final kissing and the re-stenting.
I did complete final kissing also, left mid.
No, but the left main distal was not covered by the stent. You did the ostial.
Yes, ostial left mid to the circumflex was the stent.
Ostial left main to circumflex. You did the pot. No.
That's the one. Then it is crossed. Then it is stent in the tank.
You have loved to put the balloon direct first report to the university because there was some possible to it, there was some reasons there. Probably that would have been there. Same way for RC also post IVL, probably a balloon would have again told us that yes, we have had a preparation delivered that. Second, it was wiser to do a leg first because leg was already in market and RC was the supporting.
No, that was my initially I thought that.
And then do leg probably may not have.
So one final thing, the two stents, the geographic base was how many millimeters? 1 millimeter.
1 millimeter.
I think I wouldn't have stented it. I mean, that is just increasing another stent strap within those two stents, and it was such a bad vessel, and you have done such a good job. I wouldn't have stented. That is the only thing that I would pick on this.
Okay, the last question.
This patient had got so many things and I did not wanted him to come back again.
Sir, I saw that you are using IBP. So routinely you are using IBP in these kind of cases, and how long you keep it?
I don't use routinely IABP, and if at all IABP is used, it has to be for a very short period, and the moment if you see that the blood pressure is coming up, I try to take off the IABP.
Okay, thank you, Dr. Suresh.
Just a quick comment. IBP should always be used in such cases. There should not be any question of not using it.
Okay, now call upon Professor Kashpal Sharma, who will talk on the challenging primary PCI case.
Good afternoon. I think my case is also like this, where cardiac shock, primary angioplasty. Basically, the difference between primary angioplasty and cardiac shock, it is totally, if you read, it's not there. The cases which were taken for during primary angioplasty for cardiac shock, they were excluded from the primary angioplasty, and the mortality was 4 to 6%. Cardiac shock has a mortality of have been to the tune of 70 to 80%. Then it decreased to latest in the New England Journal 50 to 60% all over the globe. Wherever this primary angioplasty, this PAMI and all trials were done, the patient of high risk, they were all excluded. Ostial, left main, ostial, all lesions were excluded with comorbidity. So it is a very thing, whatever you label it as primary angioplasty, whether it's primary angioplasty or a default primary angioplasty, because those high-risk patients, they are excluded. So just read the primary angioplasty because of primary angioplasty saying many of the doctors and paramedicals, 25,000 during COVID, they just are nowhere in this world now because this was a misnomer. And during web cardio, I think Dr. Vivek Gupta remember when we had a discussion and told them that don't take these patients immediately for
with great stones.
So I will just start now because it's important, because this is such a knowledge you will gain today, then you will decrease your mortality of cath lab to the tune of 60 to 70%, whatsoever sick patients are there. So I just present a case who was just recently, there are so many such patients, because every patient is challenging, because we treat cardiac shock and very sick patients with a ejection fraction of 10 to 15%, which are referred from all over the hospital and from the surrounding area. So this was a 66-year male who was a long diabetes and hypertensive, presented with chest pain and syncope, blood pressure 70, drowsy, and he was in pulmonary edema. Actually was 10.5, hemoglobin 3.2, count 14,500, CRP 86, and creatinine 1.8. So ECG was showing immediate and posterior impact with AV dissociation. There was ejection fraction was 25 to 30% and moderate mitral regurgitation. And this patient was immediately intubated because of poor sensorium, and loading dose were given bicular IVU, TPA placed, and this paracetamol infusion, and when the blood pressure stabilized, this low-dose Nicoran infusion was started with BP monitoring. All drugs, cardiac protective was given, including albumin, low dose, and sensorium improved after 48 hours activated. Then angiogram was done at 72 hours. So angiogram was showing this diffuse LED circumflex and RCA was also showing proximal critical disease with this disease in the distal segment also. So then we just on the day took this patient for RCA angioplasty, and ejection fraction improved to 35 to 40%, and then subsequently the patient was built up because all the parameters were done normal, and after a week we did angioplasty of the RCA. It was a very tough lesion. The field was very secure type, and we crossed it with feeder SPA and changed it to the run-through wire and two stents, also in the distal part and one in the proximal part was. So there was a good flow, and circumflex it was done 2 months back. The patient improved, blood pressure and everything was normal, and ejection fraction improved to 40 to 45% after doing LED, and on last follow-up about week back, 2 months after, the ejection fraction has improved to 50%, and he was on continuous follow-up every monthly. With this 6 months, we will do a check short of cardiac and see the right, the circumflex also. At that time, we will have the right and LED stent also. The question, what should be the approach to such patients with AMI with cardiac shock? Whether immediately do an angioplasty or just improve the hemodynamics, ventilation, other things, and then take up. Because if you take immediately, the mortality is 90 to 100% of such patients, or even 50 to 60% whatsoever. So basically, there was the trial where PAMI started. In that, all these, if you see, the high-risk patients were excluded. So all this relevant in the present scenario, the patient-centric approach should be there. Because we were doing primary angioplasty, I was, of course, 2005. Many patients with acute MR, we used to open the LED circumflex and they used to die. And they used to ask, Doctor, you have done something, what happened? They went up to the United States, showed those healing. So I told them that there is such. After that, we shifted to have a very close, search on cardiac shock, more than 30 cases, more than 1,000, 2,000 patients. We saw critical factors what lead on to the death. Why there is a death? They should not be. And then cardiac shock, because as I told, all these patients were excluded in the primary angioplasty. The cardiac shock, renal failure, CVA, sepsis, AMI, left main, bifurcation, osteal lesion, large vessel even they were excluded. So then at that time they were compared with only the thrombolysis. Nowadays if you're doing doing thrombolysis, you are taking them next day or whenever the patient is fit. You never discharge that patient or ask them to come after 3 weeks or do TMT. You always give the proper treatment whenever the patient is discharged.
Time, Dr. Sharma.
Yes. So basically, I will just in that way tell that our mortality, which was in 2010, 52% has cardiac shock decreased to single digit, 8.9%. And during COVID, it was also reached 2020, it was 9%. Basically, this, I just tell you that 30-day mortality, our paper PCI history of 1,200 patients, 30-day mortality of cardiac shock, 14.7%. Then epidemiology 5 days has been published in Indian Heart Journal, the rate cardiac shock, this similar patient of acute MR, this and cardiac shock, we did this angioplasty in 2021 and has been published in Asian Journal. So experience during COVID has been tremendous of saving maximum number of patients, and this strategy was given to the whole globe by Indo-European webinar, which was moderated by Vivek Gupta. And this global market during this was PLC, infections, international volume, albumin, and increased urea creatinine. They were the cause of death during COVID. So CTO last approach has been given from PGI, culprit only has been given from PGI, and strategic management patient specific approach of this cardiac shock. This is a paper published of CTO in Indian Heart Journal. So this during 2022, the PGI was rated among the first 10 in the world, and the Mayo and this doctors, faculty from all, they came to see PGI cardiology department, including Mandeep Singh and Gurinder, those who are chairman and directors. Nowadays it will be, this one, though we are at 100 or something, but because of workload and other things. But other hospitals are also aspiring to be in the list, and they are all Indian ranking has started, and you are reading in the papers. So just I tell you that patient-centric approach that saves the life. If with pneumonia and renal failure the patient is taken without this, and the patient, you open the artery, but the patient dies, that is the cause for mortality. So always have a patient-centric approach, then the mortality will be, I think, single digit, and India will take a lead to decrease the mortality. And some also started saying that she is the Indian scientists and doctors, but they have decreased the prices of the patents have been being broken to decrease the mortality in the United States. Thank you.
Thank you.
There is no doubt that PGI has a large volume. Your data has to be really considered in a big way, and you should be thankful to show the data. And PGI Chandigarh, you are one of the main stream. I just wanted to know from you that, of course, those patients who are late, but there are patients who come quite early. Of course, there should not be any doubt not to do a primary angioplasty in those cases. Of course, even despite the worst of the anatomy, you should do culprit vessel and do the culprit and then delay the revascularization for the other vessels. But of course, when the patient comes beyond 12 hours, early revascularization may not be so important as you say. And this is what Greg Stone also agreed at that time when we did a webinar during the COVID with Greg Stone and many other people who were there during the Indo-European webinars. So anything else?
Yeah. So brilliant. It has come down to 14.7. Okay. My question is, we follow the same approach. We don't take really very sick patients. We try to stabilize them and do it. Someone who's lactate is 10, we don't do it. Someone who has white out in the lungs, we don't do it. Someone, your patients have sepsis, we don't do it because we know they will die of renal failure or multi-organ failure. My question, however, is, what I want to know is, so you waited, which is what I would do as well. How many of those patients, what percentage of those patients died while waiting? So that gives us a more granular idea of what the real mortality rate is.
Our this registry of PGI of 1200 patients is a real world registry, including all those patients who have been done angioplasty, not done angioplasty, gone for surgery. This is not that we pick and choose. All patients' mortality, this is the data.
No. I'm asking a very specific question. So we are talking about cardiogenic shock.
Cardiogenic shock.
So where you are waiting, you go and you assess and you say, okay, this patient is not ready.
We are always 24/7 ready. If the patient is
that is not the question, sir. you showed a patient where you waited for 72 hours, and because the patient was not getting it. So you would have a cohort of patients where you have to wait such a duration, say 48 to 72 hours. My question is, and you do the angioplasty and you report that the mortality is 40.7. What I am asking is, what percentage of these X number of patients died before you could take them up for angioplasty while they were waiting? That is what I want to know.
That's what I'm telling you, that they get stabilized and then we do angiography. No patients, they told only that number 8% have died.
So,
out of
the patient who were getting the supportive management during the period of say 72 hours, so there was no mortality.
But I tell you, whatsoever this data of, there were 100 patients in the latest, there were 15 cardiac shock, 85 were without cardiac shock latest, and out of 15, only 2 deaths were there, and 85 there were 2 deaths. There were total 4%. That's what I'm telling you.
Okay, thank you.
If you have any...
Thank you, Dr. Sharma. Thank you very much. So, the last speaker I will call upon, Dr. Nitish Chandra, who will talk on imaging in primary PCI. He is not there? He is not there?
But we can have a quick discussion on this actually.
So, any comment from the floor on the last case? What Dr. Sharma has done is very interesting.
Dr. Raj.
Dr. Raj is a pioneer.
Would you like to say something?
Large volume and data speaks itself. So then it's 2 days only out of 100 patients cardiology shock.
No. 15. Out of 100, 15 patients were cardiac shock, 85.
2 patients were cardiology, 2 days in cardiology shock.
Out of 15.
Yeah, cardiology shock. I think that is the real world data. And that is what gives the message that these patients are to be first stabilized, then taken first 100%, not to immediately.
And not to culprit only.
Yeah.
You are saying culprit only.
True.
So all the things is okay, but one thing is that patient with cardiac shock, it comes and it doesn't have like infection or other
প্লেন তো বিকেলে চেক আউট করতে হবে চেক আউটটাই করি
আমিও করি রাইটে করবো চলে এসছে
That patient, you show the data, then if there is a single digit mortality.
Yeah, I mean, some patients, we agree, some patients are really very sick. We know that they are going to die. We have all seen it. We have all done angioplasties in very sick patients in cardiac shock, and they have died from some other cause. I mean, we have done good angioplasty, despite that the patients have died. Most of them die of renal failure and sepsis.
Other causes.
Yes, they do die. And so there's no problem with your approach. We agree what we are trying to get is idea of what type of mortality you have. So any other questions?
Dr. Paja, any comment?
No, actually, just reverse to the management of the unstable angina. You have to do the primary angioplasty as whole quickly. No question of pulling off time. Don't wait. Previously, you have to wait in the unstable angina. Now, within few hours, that is within 10 to 12 hours, you do the intervention. And that group of patients, just reverse of your patient.
Basically, you are taking next day, whatsoever you investigate into patients, HB 6-7, and
Correct.
the patient creatinine is 12, and without this you are taking, what will happen?
No, they will die. Okay, yeah. So, Dr. Bhatia. So, regarding your series of cases, you did 100 cases, right? So, did you follow them up for 1 year?
Yes, sir.
They are all MI patients, so tell us what the mortality rate is,
Sir,
and tell us what is it in comparison to other studies in MI.
Sir, we have 6-month follow-up data, clinical as well as echocardiographic. So all the patients have completed 6 months. Not every patient has some